talking to Sarah Doernberg, who's Associate Professor of Medicine in our ID division at UCSF Health and is the Medical Director of Adult Antimicrobial Stewardship, and has found herself smack in the middle of infection prevention efforts as they relate to COVID. So Sarah, first, thank you for doing this. And tell us what if you can remember what your job was until a month ago.
Well, thanks for having me. Yeah, until a month ago, I did a mix of three main activities. One was as medical director of our antibiotic stewardship program, where my job was to make sure that we were using antibiotics as appropriate, right antibiotic for the right person at the right time in the hospital and the health system. And then I do clinical research related to antimicrobial resistance and take care of patients, both in the inpatient and outpatient setting, with a focus on transplant infection.
And I imagine folks like you have trained for something like this all your career in a way. When you first heard about the outbreak in China, what did you think and did you imagine it would grow into what we've seen?
But when I first started hearing about it, I knew that it could become something real and something that we could see, and definitely something that we have started thinking about and planning for before this even happened. Just being prepared as a hospital and a health system for the possibility of a pandemic.
Okay, why don't you just sort of lay out the biggest issues, the hardest issues that you've had to deal with? I assume some of them have to do with this issue of PPE and both supply and the complicated decisions you have to make. So take us through kind of how you thought about it and then how it actually played out.
Yeah, I think many of the biggest issues around this pandemic stem from the fact that we're still learning about how this virus spreads, what the clinical manifestations are, how best to test patients. And so in the setting of a lot of uncertainty, there's a lot of anxiety, and in addition to that, coupled with that, is there have been supply chain issues really for every step of the way through the supply. So initially it was getting adequate testing, just the access to testing, and our inability to test meant we put a lot of patients in isolation because they may or may not have COVID, and we couldn't know for sure when we had to go through the Department of Public Health. And once that became something that we had worked through and we got testing on campus, there became limitations with our reagents for testing, our ability to swab patients that also limited our ability to make the diagnosis. And that was a challenge for a while and continues to be a challenge. And then some of the more recent challenges have come around shortages in personal protective equipment. And these are national supply chain issues that are affecting most hospitals in the United States right now, unfortunately, and have really led to a lot of challenges. We want people to be comfortable taking care of patients, and we've tried to take a rational approach to keeping everyone protected and safe, while still ensuring that next week we'll be able to safely care for patients who have COVID-19.
So take us to a fantasy world where in the beginning of this you'd had sufficient supplies of both testing and PPE. What would the response have looked like? I'm not talking about sort of nationally or internationally, but as in your job, what would the recommendations have been different? How would that have played out?
Yeah, I mean that the test availability would have really changed the game early, because I think the more patients we can identify rapidly with the infection, the more we are able to do contact tracing and identify other people who may have been exposed, understand this whole concept of presymptomatic spread of infection, which is a concern and is really poorly understood still. So I think being able to do widespread testing, including epidemiologic studies of patients in the community, so we could really understand what the prevalence of infection is in our city, would be very helpful to inform our personal protective approach. For instance, when a patient comes in who has no symptoms, how concerned do we need to be about the potential that they have COVID-19? And
So if we had truly unlimited testing, would we be testing every? I mean, how would you then make the decision? Do you test everybody who comes into the emergency room with anything? Do you test the entire general population? And in thinking about that, you know, the epidemiology is still a little bit uncertain, but it does seem like there are, quote, false negatives. There are people who are negative and then turn positive later.
absolutely. So I think that the testing of patients without symptoms would have to be in an epidemiologic study where you're learning to understand who we need to be concerned about and who we need to test. Testing asymptomatic people coming into the hospital doesn't make very much sense because we suspect that those tests are going to be less sensitive than symptomatic patients, so we don't have good data on that. And so a false negative or a negative test may mean a true negative. It may mean a false negative because someone's incubating or their viral loads are low, or for some other reason we have a false negative. So it doesn't provide that much information. Plus, just because it's negative today does not guarantee a negative tomorrow or the next day or the next day. But I think having more ready availability of testing to be able to study on a population level what's happening with the virus would really inform our approach to safely caring for patients in the hospital.
And when people talk about false negatives, I assume that if, maybe I'm wrong about this, that if you test negative and it turns out you're positive or you turn positive a day or two, your viral load may have been lower and therefore you may not be as contagious as you might have been. So even though it's sort of negative in the true sense of the world, we're partly testing to see how infectious you are, and maybe that tells us something about how infectious you are. Is that correct, or am I making that up?
I think that's one possibility, but there are multiple other possibilities. First, the other one is that there's some operator skill needed to take a nasopharyngeal swab. So I suspect that some of the negative tests may be that the swab was not put in the right spot or left up in the nose for 10 seconds to get a good enough sample. So some might be sampling error. And then we know from other respiratory viral infections that respiratory viruses that affect the lower respiratory tract, sometimes you have negative nasopharyngeal testing, which is our primary mode of testing. So there may be patients in whom having a lower tract specimen would be positive, and they may be equally infectious, but they have a negative MP swab.
Got it. All right, let's talk about PPE. None of us even heard of PPE till a month ago, and now it's all we talk about. So how has the shortage influenced our approach and your thinking about this? And if the shortage lets up, how will that change the approach?
Well, currently we have guidelines for reusing and extended use of personal protective equipment. This is not something that we typically do when PPE is flush. So these are guidelines for how to safely use a mask over again. You know, you take it off and keep it in a dry place in between. We're recommending face shields to try and protect those masks from becoming soiled. And then there are certain situations where extending use of the PPE, so wearing it for a long time rather than taking it off as you go, may be appropriate as well in certain settings. So those are things we don't typically do, and were our PPE supply to become all of a sudden open up, I think we would probably move away from that again. And then, you know, there's, as I mentioned, a lot of uncertainty about this concept of presymptomatic spread and concern that high-risk procedures may place healthcare workers at risk for patients who we may not recognize the risk of COVID-19. And there's been a lot of discussion both here and at other medical centers about how best to approach those patients. And I think in a setting of unlimited PPE, we would probably be more liberal with allowing people to choose what makes them feel comfortable.
And so let's talk about that. That seems to be probably the hottest issue these days, sort of born in part of Atul Gawande's article that seemed to have triggered certain large systems, including Harvard and Sutter, to recommend that everybody wear surgical masks all the time. assuming we had an unlimited supply, is that a reasonable thing to do? Are we just sort of treating people's anxiety and understandable anxiety? Or when someone comes up to me and says, can you prove with 100% certainty that when I go into the room of someone who's not aerosolizing anything and but is just sitting there breathing and is there for rule out COVID, that there is zero risk? And I don't quite know the answer to that. So how are you thinking that through?
Yeah, it's you know, I wish we had more information to make these decisions right now. There have been studies with other settings, so not in the pandemic setting, in certain situations where universal masking policies, typically these are done on areas where they're very immunocompromised patients, can lead to lower rates of nosocomial viral infections. So, you know, it stands to reason that perhaps that might help prevent the spread of viral infections within a facility. I think there are some valid concerns about this. The masks are probably not effective after they get wet when someone's been breathing on them for a long time. It's possible to contaminate yourself with the mask on, and so you know it's deviating from what we normally do can sometimes lead to actually more contamination than we intend to, and certainly wouldn't want people to feel like they don't need to wash their hands or clean their hands as often because they have this kind of layer of perceived protection. So I think anything like this would need to be done very carefully. And you know, the actual volume of masks that would be consumed making a policy like this is astronomical. So it's definitely something that needs to be done under careful consideration.
Okay. But at this point, if a big truck showed up at the warehouse today and delivered 1 million surgical masks, do you think we would go in this direction, or you still think it requires some more discussion?
I think it would require some more discussion, but there certainly is a lot of pressure to consider an approach like that, given the amount of uncertainty.
Yeah.
This is where going back to the discussion of our understanding of this concept of pre-symptomatic spread would really inform our approach. If we knew that really people had symptoms and they were just very mild at the outset, and that was what this kind of asymptomatic spread that's made such a splash was, it might be considered very differently than truly asymptomatic people.
Got it. Talk a little bit about the communications challenges in this kind of thing. It sometimes strikes me that it's demonstrating the tension between evidence-based medicine and existential dread, and trying to get that right in a rapidly changing environment with social media and news coming all the time and conflicting messages is just a brutally hard challenge. So how are you thinking about that? And what have you learned in the last month?
Yeah, so I think there's multiple layers of communication. There's kind of the communication from the press to the public. There's communication from the scientific community with peer-reviewed articles and pre-printed articles, and then there's communication within our health system, which also is a challenge. I've been disappointed at times about how rapidly anecdotal stories have entered the news, entered the medical vernacular as truth, and I think it's very important during this time to remember evidence-based medicine is really crucial, and that taking an anecdote can be dangerous, that doing something just because one patient showed improvement, applying it to all patients without studying it, can lead to harm. And this is something that, you know, we see with antibiotic stewardship pretty frequently, where people have a patient in front of them, they want to give antibiotics to be on the safe side, but then we can do harm to a patient. And so it's similar concepts with some of the stories of hydroxychloroquine, for instance, where the evidence behind that is pretty thin and certainly needs additional study, but before it becomes kind of the national recommendation, I think it needs to be vetted more thoroughly.
Yeah.
And then communication on kind of an institutional level is another challenge, because there's such a complex place to communicate to a whole academic center. And I think that the people in the middle of it have a good sense of what's going on, but sometimes communicating to everyone who's involved in caring for patients and running a hospital can be a challenge.
Any other lessons that you've learned, things that you did not know a month ago and now you've learned the hard way?
Well, I think one of the great things that I've learned is how to work as a true interdisciplinary team with my colleagues, and really everyone across the organization has come together to address this response. And so that's been a nice thing to see and to learn and to get to know people from other disciplines in ways I hadn't previously known.
Right. Maybe last question. You know, a lot of discussion about why at UCSF today's Thursday, we're not seeing the kind of surge that they're seeing in New York and New Orleans and a few other places. First of all, what's your theory about that? And second of all, do you think we are pre-surge or we're dodging the bullet?
Well, I wish I knew for sure, and I guess I'm going to take the optimistic approach. A couple of thoughts about this. One is, I think San Francisco and our Department of Public Health really put in some social distancing measures earlier than some other cities. And I think that that's contributing to what we're seeing, though certainly remain ready for a surge of patients to come in the next weeks. And then I've heard speculation about our population being a bit younger and healthier, and perhaps that's also contributing, that our demographic is a little bit different. Compared to New York, we're a little bit less dense of a city. That may also be contributing as far as spread of infection goes. But it's a little soon to know if next week is going to bring a surge that we're have been preparing for all of these.
How will we know when we're out of the woods?
Oh, that's $1 billion question.
I think probably $1 trillion. I think, actually.
I think when we have an effective vaccine that a lot of people can get, we'll feel like we're out of the woods. Until then, I think there is going to remain the possibility that this virus kind of causes sporadic disease and infections in various places as we release some of our social distancing in the future at some point.
Great.
And it's something that our public health departments are going to have to really monitor and keep an eye on as we do reverse some of that many weeks in the future.
Sarah, thank you so much for all you're doing and for your leadership. Really, really appreciate it. And thanks for taking the time.
Thanks for having me.
Okay, see you later.